Thyroid conditions. The thyroid gland is a butterfly-shaped organ located in the lower neck, anterior to the trachea. It consists of two lateral lobes connected by the isthmus. The gland is 5 centimeters long and 3 centimeters wide. The blood flow to the thyroid is very high, approximately 5 times the blood flow to the liver. This reflects the high metabolic activity of the thyroid gland. The thyroid gland produces 3 hormones: thyroxine, or T4, thyroxine, or T3, and calcitonin. T4 and T3 are referred to collectively as thyroid hormone. T4 contains 4 iodine atoms in each molecule, and T3 contains 3. These hormones are synthesized and stored bound to proteins in the cells of the thyroid gland until needed for release into the bloodstream. About 75% of bound thyroid hormone is bound to thyroxine-binding globulin, or TBG. The remaining bound thyroid hormone is bound to thyroid-binding prealbumin and albumin. Iodine is essential to the thyroid gland for synthesis of the hormones. In fact, the major use of iodine in the body is by the thyroid, and the major derangement in iodine deficiency is alteration of thyroid function. Iodide is ingested in the diet and absorbed into the blood in the gastrointestinal tract. The thyroid gland is extremely efficient at taking up iodide from the blood and concentrating it within the cells, where iodide ions are converted to iodine molecules, which react with tyrosine, an amino acid, to form the thyroid hormones. The secretion of T3 and T4 by the thyroid hormone is controlled by TSH, also called thyrotropin, from the anterior pituitary gland. TSH controls the rate of thyroid hormone release. The primary function of thyroid hormone is to control cellular metabolic activity. T4, a relatively weak hormone, maintains body metabolism in a steady state. T3 is about 5 times as potent as T4 and has a more rapid metabolic action. These hormones accelerate metabolic processes by increasing the level of specific enzymes that contribute to oxygen consumption and altering the responsiveness of tissues to other organs. Hyperthyroidism is the second most prevalent endocrine disorder after diabetes mellitus. Graves' disease, the most common type of hyperthyroidism, results from an excessive output of thyroid hormones caused by abnormal stimulation of the thyroid gland by circulating immunoglobulins. It affects women 8 times more frequently than men, with onset usually between the 2nd and 4th decades. It may appear after an emotional shock, stress, or an infection, but the exact significance of these relationships is not understood. Other common causes of hyperthyroidism include thyroiditis and excessive ingestion of thyroid hormone. Patients with well-developed hyperthyroidism exhibit a characteristic group of signs and symptoms. The presenting symptom is often nervousness. These patients are often emotionally hyperexcitable, irritable, and apprehensive. They cannot sit quietly. They suffer from palpitations, and their pulse is abnormally rapid at rest as well as on exertion. They tolerate heat poorly and perspire unusually freely. The skin is flushed continuously with a characteristic salmon color and is likely to be warm, soft, and moist. However, elderly patients may report dry skin and diffuse pruritus. A fine tremor of the hands may be observed, and patients may exhibit exophthalmos, or bulging eyes, which produces a startled facial expression. Other manifestations include an increased appetite and dietary intake, progressive weight loss, abnormal muscular fatigue, and weakness. There's often difficulty in climbing stairs and rising from a chair. amenorrhea, and changes in bowel function. The pulse rate ranges constantly between 90 and 160 beats per minute. The systolic, but characteristically not the diastolic, blood pressure is elevated. Atrial fib may occur, and cardiac decompensation in the form of heart failure is common, especially in elderly clients. Osteoporosis and fracture are also associated with hyperthyroidism. Cardiac defects may include sinus tachycardia or dysrhythmias, increased pulse pressure, and palpitations. It has been suggested that these changes may be related to increased sensitivity to catecholamines or to changes in neurotransmitter turnover. Myocardial hypertrophy and heart failure may occur if the hyperthyroidism is severe and untreated. The course of the disease may be mild, characterized by remissions and exacerbations, and terminating with spontaneous recovery in a few months or years. Conversely, it may progress relentlessly, with the untreated person becoming emaciated, intensely nervous, delirious, and even disoriented. Eventually, the heart fails. Appropriate treatment of hyperthyroidism depends on the underlying cause and often consists of a combination of therapies, including anti-thyroid agents, radioactive iodine, and surgery. Treatment of hyperthyroidism is directed toward reducing thyroid hyperactivity to relieve symptoms and preventing complications. Use of radioactive iodine is the most common form of treatment for Graves' disease in North America. Surgical removal of most of the thyroid gland is a non-pharmacologic alternative. No treatment is without side effects, and all three treatments, radioactive iodine, antithyroid medications, and surgery, share the same complications: relapse or recurrent hyperthyroidism and permanent hypothyroidism. The rate of relapse increases in patients who have had very severe disease, a long history of dysfunction, ocular and cardiac symptoms, large goiter, or relapse after previous treatment. The relapse rate after radioactive iodine therapy depends on the dose used in treatment. Patients receiving a lower dose are more likely to require subsequent treatment. The objective of pharmacotherapy is to inhibit one or more stages in thyroid hormone synthesis or hormone release. The therapeutic dose is determined on the basis of clinical criteria, including changes in pulse rate, pulse pressure, body size, size of goiter, and results of laboratory studies of thyroid function. Because antithyroid medications do not interfere with release or activity of previously formed thyroid hormones, it may take several weeks until relief of symptoms occurs. At that time, the manifestation dose is established and a gradual withdrawal of the medication over the next several months occurs. Toxic complications of antithyroid medications are relatively uncommon. Nevertheless, the importance of periodic follow-up is emphasized because medication sensitization, fever, rash, or even thrombocytopenia may develop with any sign of infection, especially pharyngitis and fever, or with the occurrence of mouth ulcers. The patient is advised to stop the medication, notify the physician immediately, and undergo lab work. The wide-eyed or startled look of Graves' disease is due to the edema in the extraocular muscles and increased fatty tissue behind the eye, which pushes the eyeball forward. Pressure on the optic nerve may impair vision. Swelling and shortening of the muscles may cause problems with focusing. If the eyelids fail to close completely and the eye is unprotected, the eye may become overly dry and develop corneal ulcers or infection. A goiter is an enlargement or hypertrophy of the thyroid gland. It may occur with deficient or excessive or normal thyroid hormone secretion. It can be congenital or acquired. Congenital disease usually occurs as a result of maternal administration of antithyroid drugs or iodides during pregnancy. Acquired disease can result from increased secretion of pituitary thyroid stimulating hormone in response to decreased circulating levels of thyroid hormone, or from neoplastic or an inflammatory process. In areas where dietary iodine is deficient, goiter can be endemic. Enlargement of the thyroid gland may be mild and noticeable only when there is an increased demand for thyroid hormone, especially during periods of rapid growth. Where iodine deficiency is severe, a large percentage of the population displays goiters. Enlargement of the thyroid at birth can be sufficient to cause severe respiratory distress. Sporadic goiter is usually caused by lymphocytic thyroiditis and intrinsic biochemical deficits or defects. Thyroid replacement is necessary to treat hypothyroidism and reverse the thyroid-stimulating hormone effect on the gland. Iodine-deficient areas in the U.S. have a higher incidence of goiter, the Midwest, Northeast, and Great Lakes region, and 29% of the world's population live in iodine-deficient areas. Goiter can be sporadic or not related to any geographic region, have a genetic defect component related to malfunction of iodine metabolism, or be caused by ingestion of large amounts of nutritional goitrogens, or goiter-producing substances that inhibit thyroxine production. These foods can include cabbage, soybeans, spinach, or medicinal goitrogens, such as glucocorticoids or dopamine or lithium. So health promotion includes educating and encouraging the use of iodized salt and avoiding those goitrogens. Classification of goiter: 0 is no palpable or visible goiter. 1, the mass is not visible with neck in the normal position, but goiter can be palpated and moves when the patient swallows. 2, the mass is visible as swelling when the neck is in normal position. The goiter is easily palpated and usually asymmetric. The classification status is defined for treatment parameters. Medical management and nursing considerations includes the administration of iodine and thyroid hormone solutions, SSKI drops, or potassium iodide, which reduces the size and vascularity of the enlarged gland, promote a diet rich in iodine, discourage those goitrogens in the diet that we just discussed. And then if it's an endemic goiter, that can be avoided with the use of regular iodized salt. Children should have 50 to 120 micrograms a day, and adults 150 to 300. And here's a slide that just shows the variations in the goiter. Thyrotoxic crisis or thyroid storm is severe hyperthyroidism, often exhibited with a high fever, extreme tachycardia with palpitations, weight loss, diarrhea, abdominal pain, altered neurologic state with delirium, somnolence, even a coma. Usually it's precipitated by stress, injury, infection, or an abrupt withdrawal of thyroid meds or uncontrolled blood glucose. Treatment includes reducing body temperature and preventing vascular collapse, salicylates, and then hypothermia treatment for fever, oxygen, dextrose IV to replace the liver glycogen stores that have been depleted, medications to block conversion of T4 and T3, hydrocortisone to treat adrenal insufficiency if present, iodine to decrease output of T4, and then beta blockers combined with DIG to reduce cardiac symptoms. Hypothyroidism results from suboptimal levels of thyroid hormone. More than 95% of patients with hypothyroidism have primary or thyroidal hypothyroidism, which refers to dysfunction of the thyroid gland itself. If the cause of the thyroid dysfunction is failure of the pituitary gland, the hypothalamus, or both the pituitary gland, the hypothalamus, or both, the hypothyroidism is known as central hypothyroidism. If the cause is entirely a pituitary disorder, it may be referred to as pituitary or secondary hypothyroidism. If the cause is a disorder of the hypothalamus resulting in inadequate secretion of TSH due to decreased stimulation by TRH, it is referred to as hypothalamic or tertiary hypothyroidism. If thyroid deficiency is present at birth, the hypothyroidism is known as cretinism. Key features or manifestations can include skin that is cool, pale, yellow, dry, coarse, scaly, thick, brittle nails, dry, coarse hair, decreased hair growth, loss of eyebrow hair, or poor wound healing. Pulmonary can include hypoventilation, pleural effusion or dyspnea, cardiovascular, bradycardia, dysrhythmias, enlarged heart, hypotension, decreased activity tolerance. Metabolic, there's decreased basal metabolic rate and temperature, so they're cold intolerant. Musculoskeletal, muscle aches and pains, delayed contraction and relaxation of the muscles. The neurological, impaired memory, slowed speech, inattentiveness, lethargy, confusion, hearing loss, decreased tendon reflexes, paresthesia, and extreme numbness. Additional key features for psychological, there's apathy, depression, paranoia, withdrawal. GI is anorexia, weight gain, constipation, abdominal distension. Reproductive complaints with women, amenorrhea, decreased libido, and no cycle or involution or no cycling for menses. Men, impotence and decreased libido. And then other complaints would be paraorbital edema, facial puffiness, non-pitting edema, hoarseness and thick tongue, anemia, easy bruising, increased sensitivities to opioids and tranquilizers, weakness, fatigue, vitamin B deficiency, iron and folate deficiency. Myxedema often describes the more extreme severe cases of hypothyroidism. And you'll have most tissue and organs that are affected by the low metabolic rate, so the cellular energy is decreased and metabolites build up. Metabolites are compounds of proteins and sugars that build up in the system and inside the cells that increase mucus and water and change organ structure. The edema is mucinous rather than edema from water alone. Patients with this appearance change. They'll have non-pitting edema that forms everywhere, especially around the eyes, hands, feet, and between their shoulder blades. Their tongue thickens, and edema in the larynx makes their voice sound husky. Myxedema coma is relatively rare but does exist, and it is when the patient is not treated. They may develop an undiagnosed hypothyroidism and then have a precipitating infection or other systemic disease. So there's decreased metabolism, which affects heart tissue, decreased cardiac output, decreased perfusion to the brain and vital organs. The decreased perfusion makes slowed metabolism worse, resulting in tissue and organ failure. Death from myxedema coma is high. Treatment for hypothyroidism includes lifelong thyroid replacement. Starting dose needs to be monitored. You want to avoid hypertension, heart failure, or MI. Instruct the clients on signs of hyperthyroidism, and dosing needs are adjusted with age as metabolic demand increases, and assess for cardiac disturbances in elders that are on thyroid replacement. This just gives you another look at all the different manifestations of hypothyroidism. Juvenile hypothyroidism is the most common endocrine problem of childhood. Can be congenital or acquired. Congenital hypoplastic thyroid gland can produce enough thyroid hormone during the first few years, but inadequate as the child ages. Often radiotherapy for childhood cancers can lead to hypothyroidism. And then there can be a primary congenital hypothyroidism characterized by low levels of circulating thyroid hormone at birth. Presenting symptoms are impaired growth and development, skin changes, dry skin, sparse hair, constipation, sleepiness, mental decline, puffiness around the eye. Early recognition means early treatment and diminished long-term effects. and your treatment or nursing care is the same as the adult, lifelong thyroid replacement